All right, let's go ahead and get started. Good evening, everyone, and thank you for joining tonight's July 2022 edition of Eversight's webinar series. Tonight, we have a very exciting topic, artificial iris or artificial cornea, a tale of two prostheses. And that's going to be presented by Dr. Ahmed Omar, who's joining me here. All participants will be muted throughout the duration of the webinar. Please type any questions that you have into the Q&A panel throughout the webinar. We'll answer those at the end. We're also going to try at the end to do a couple of polls that I just put into the webinar, and hopefully they will work, but the audience will be able to weigh in on a couple of cases at the end. This webinar will be available on our website in the days to come. Please don't forget to register for our September webinar, Current Practice Patterns for IOL Calculations in Patients with Corneal Disease with Dr. Kamran Riaz, and our October program, Passaic Surgery in the Glaucoma Patient with Dr. Daniel Montenegro. And now I'd like to briefly introduce our speaker for tonight. Dr. Omar joined the cornea service at University Hospital Eye Institute in Cleveland in May of 2019. He is a graduate of Assiut Medical School, completed his internship and ophthalmology residency at Assiut University Hospitals in Egypt and joined their faculty in 2008. On scholarship from the Egyptian government, Dr. Omar joined the Mayo Clinic in 2011 to conduct his PhD research and then a medical retina fellowship at Harvard Medical School. He completed a cornea, refractive, and external disease fellowship at the University of Texas Southwestern Medical Center in 2016 and moved back to Egypt to share his knowledge and experience with his patients and colleagues. In 2017, Dr. Omar helped establish an Egyptian government-sponsored program to provide cornea transplants for underprivileged Egyptians at Assiut University Hospitals. He taught many of his colleagues to do corneal transplants individually so that they could continue to provide the same level of care when he returned to the United States in 2019. And now, Dr. Omar, the floor is yours.
Thank you so much. Good evening, everyone. This is Ahmed Omar again, and I would like to thank Eversight for the opportunity to speak tonight. I have no financial interest in any of the products presented in this presentation. So from the title of the presentation, you know that I'm going to talk about two prostheses used by corneal surgeons, the artificial iris and the artificial cornea or keratoprostheses. I would say, although they seem unrelated, but both prostheses are used in complex anterior segment surgeries, particularly after ocular trauma. I'm going to touch over a couple of cases at the end of the presentation that I felt there could be a choice between the two prostheses as far as which could be used for vision rehab for those two patients. So first, I'm going to talk about the artificial iris. Briefly, like a brief history, that the first attempt at an iris prosthesis was in the 1950s by Dr. Peter Choice in the UK. And then in 2018, that artificial iris, the human optics custom flex artificial iris was approved by the FDA. So the custom flex artificial iris, it's a hydrophobic silicone elastomer with embedded color pigments. It's a full 360 degrees prosthesis that's 12.8 millimeter in diameter, has a 3.35 millimeter pupil, and it's flexible and could be folded for easy insertion, either using an IOL injector through a 2.75 millimeter incision, or using a forceps through a slightly larger incision, 4 millimeter. It's available in two models. The Wiz fiber model has an embedded polyester meshwork, and the fiber-free model does not have the meshwork. And the placement depends on the pathology. You could place it in the capsular bag or passive sulcus fixation. And in both situations, you can use the fiber-free model. You can also implant the Wiz fiber model, also in the sulcus, passive sulcus fixation for the Wiz fiber model. Or you could suture the Wiz fiber model to the scleral wall, or you could suture an IOL ex vivo to the artificial iris implant and suture both to the sclera for patients who are aphakic and aniridic. The iris is custom made for each patient. Also, it's color matched to match the natural iris, and it could be refined for custom fit. Here is a magnified view of the artificial iris. The anterior silicone layer, it's colored, and the posterior layer also made of silicone, and it's black. And there's this is the with fiber model, has the fiber meshwork layer. Here is another view of the iris prosthesis. Another magnified view shows the natural iris surface architecture. The iris prosthesis could be used for patients who have symptoms of iris defects such as glare, photophobia, halos, nystagmus, and vision impairment. These are some indications of the iris implant: congenital aniridia, traumatic iris defects, patients with eye syndrome, patients who had surgical damage of the iris, patients with ocular albinism after melanoma excision, after excision of epithelial ingrowth, and patients with congenital coloboma. Some of the contraindications of the artificial iris implant include uncontrolled ocular inflammation, patients with severe chronic uveitis, microphthalmus, untreated retinal detachment, untreated chronic glaucoma, rubeosis, PDR, Stargardt retinopathy, and intraocular infections. These are also some of the adverse events that could happen after implantation of the artificial iris: elevated intraocular pressure, incorrect positioning, decentration, dislocation, cystoid macular edema, endophthalmitis like with other intraocular surgeries, endothelial damage and corneal edema, uveitis as part of uveitis, glaucoma, hyphema syndrome, and possible pupillary block. Surgeons who wish to implant the custom flex artificial iris are required to complete training, which is a successful completion of an online training module, and there is a test, and also a dry lab training with simuli models, where the company sends you 2 simuli models and a couple of prostheses, one with fiber and the other one with with a fiber-free model, and you implant both models into the simuli. When you're planning to do an iris prosthesis, you should take into consideration the other ocular comorbidities. These are usually complex eyes, and they could have endothelial compromise, glaucoma, synechia. Patients with ocular albinism have macular hypoplasia and nystagmus. Patients who have congenital aniridia, they also have limbal stem cell deficiency, zonulopathy, glaucoma, and of course, patients with trauma, which would be the two cases that I'm going to discuss at the end of the presentation, could have angle recession and corneal scarring. Before implanting the iris, you should do a complete ocular exam, obviously. Should check for other comorbidities, like I described earlier, corneal scarring, aphakia too. If possible, do a gonioscopy and do a fundus exam if possible. Again, if not, then you can do a B scan. And if needed, you can do testing such as corneal topography, specular microscopy, macular OCT, RNFL OCT, and UBM. When you're going to order the prosthesis, you should take pictures as instructed by the company, to take pictures of the surgery eye and the fellow eye, and a picture of both eyes together, and the picture, the hard copy printed, and you can ask the patient and the family to view the hard copy to make sure that they're satisfied. Patients with congenital aniridia can select an eye color they prefer. And finally, both the physician and the patient sign and date the photo, and the signature should not cover any part of the iris. Then you're going to order the prosthesis. There is the order form where you specify which model you'd like, the fiber-free or with fiber, again, depending on where you're going to place the implant. And they send you a backup device with the order, and it takes about 8 to 10 weeks to ship the device back to you. In patients where you're going to place the prosthesis in the capsular bag, like for instance, patients with aniridia who have cataract, you should aim for more myopia, like 0.75 to 1 diopter more myopia, because the iris implant pushes the IOL back in the capsular bag and changes the effective lens position. In these cases, you should stain the capsule with trypan blue, or in patients with aniridia ICG. It's even recommended to like stain it in the beginning of the case, like before doing the capsular rhexis, and one more time right before implanting the iris prosthesis, just to make sure that you're going to implant the iris prosthesis in the capsular bag. The rhexis size, aim for a larger size, 5 to 6 millimeter, and it's a must to use a capsular tension ring. Otherwise, you could have buckling of the device, as you can see in the images below. Patients who are like planned for passive sulcus fixation, they should have some residual iris tissue. Again, you can either implant the fiber-free or with fiber artificial iris. You should, like the triffination of the artificial iris depends on the size, or like the white to white, which you can measure outside white to white and subtract 1 millimeter. Or you can use an intraocular ruler, or you can use the UBM to measure the internal white to white. Because in some situations where you refine the device slightly smaller than the area or the white to white, internal white to white, the device could have like some micro movement that could result in uveitis glaucoma hyphema syndrome. This is a case that had the iris implanted after she had a complicated retinal detachment surgery that resulted in secondary angle closure glaucoma with like permanently dilated pupil. The patient was referred to me for cataract surgery. I attempted to do pupilloplasty at the same time. That was before I got introduced to the artificial iris implant, and I tried to do pupilloplasty at the same time, but the iris was very fibrotic, and the pupilloplasty could not be completed. So like I think 6 months or a year after the cataract surgery, I discussed with the patient the possibility of doing an artificial iris implant, and I did the passive sulcus fixation. And this is another very complex patient that had trauma about 3 years ago, had a transplant, vitrectomy for vitreous heme, lensectomy, and then he had also iris damage from the injury that could not be repaired at the time of the initial transplant. The initial transplant failed, and then I redid the transplant along with a removal of the anterior chamber IOL, and I placed a sclerofixated iris implant along with a sutured IOL to the back of the iris implant together with the penetrating keroplasty. As you can see from the picture here, there's a tube shunt superiorly that patient, of course, this is one of the side effects or the adverse events of the iris implant, is increased intraocular pressure. The patient ended up needing to have a tube shunt soon after, like a couple of weeks after the iris implant, because of persistently high IOP. Now, talking about the artificial cornea or keratoprostheses, as you all know, corneal transplantation is considered the most successful solid organ transplant. However, there is increasing demand for an artificial cornea in certain situations, such as low corneal graft survival in patients with limbal stem cell deficiency, aniridia, pemphigoid, Stevens-Johnson syndrome. Also, post-op astigmatism and anisometropia result in refractive failure for many patients who have a PK graft, even though the graft is clear and with no signs of failure or anything, but the patients could still not have useful vision because of their inability to wear contact lenses. Also, there's again demand for the artificial corneal keratoprostheses especially when a PK graft has failed. The success is less likely with each successive graft, with the 5-year graft survival rates as low as 25% for second grafts and 0% for third grafts in some patients. Again, so this is like the different types of the keratoprostheses available. Of course, the most commonly used type is the Boston Type 1 K-Pro. Also the Boston Type 2 K-Pro, which is used for more complex patients. Then the osteodontokeratoprosthesis, which is a very complex surgery done in 2 stages for patients with severe limbal stem cell deficiency that's not fixable by other measures. Then there are other keratoprostheses that are mentioned in the literature that, I'm sorry, go back one slide here, that are not commonly used: KeraClear, AlphaCore, Pentucci, or the Oro. And in this presentation, I'll be just like talking about the Boston Type 1 K-Pro, which again, like I mentioned earlier, could be used for patients who have corneal graft failure or repeated rejection, corneal scarring with extensive neovascularization, and patients with limbal stem cell deficiency, such as Stevens-Johnson syndrome, pemphigoid, aniridia, etc. When we're talking about the pre-op considerations for the K-Pro, visual acuity and potential in the surgery and the fellow eye are, of course, very important. A detailed exam is a first step in the successful placement of the K-Pro. And to optimize the outcomes, the patients should have certain essential characteristics, such as adequate lid anatomy, good blink function, sufficient tear production. The 4 niches should be evaluated given the need for a large bandage contact lens after the surgery. Peripheral anterior synechia should be noted, and the angle anatomy should be evaluated, if possible, with gonioscopy, and if not possible, maybe with anterior segment OCT. The lens status should be also determined, since the Boston K-Pro must be ordered with appropriate refractive power. It's available in either aphakic or pseudophakic versions. If an aphakic K-Pro is planned, the axial length of the eye should be measured by a scan. Of course, the surgery should be performed by a surgeon well experienced in penetrating keratoplasties, who has a direct access or works closely with a multidisciplinary team of glaucoma, retina, and oculoplastic specialist optometrists as well, owing to the frequent need for tube shunts, vitrectomy if needed, lid reconstruction around or at the time of K-Pro placement. There are 2 designs for the Boston K-Pro, Boston Type 1 K-Pro. The snap-in design is the older model, older design that is made of 4 parts. The front plate, donor cornea, then the back plate, and the titanium locking ring. The newer model is the click-on design that has a titanium back plate that locks in with the front plate with no need for a locking ring. The donor corneal tissue is placed between the front and the back plates, and one of its functions is to serve as an interface to aid in the suturing of the K-Pro to the host. And the holes in the back plate, they help deliver nutrition and hydration to the corneal graft, since aqueous access to the corneal tissue is very vital to the survival of the graft and reduces the likelihood of cornea melts. So here's the video of the assembly of the K-Pro. First, the donor corneal tissue is punched to 8.5 millimeter. Then the central 3 millimeter is punched with a derm punch that's provided with the K-Pro. Then this is the front plate, the optic of the K-Pro. And the donor corneal tissue is slid on top of the optic. Then Helon is placed on the endothelial side of the donor corneal tissue. Then the back plate, the titanium back plate, this is the click-on design. The titanium back plate is placed behind the donor corneal tissue and locked with a locking tool until a clicking sound is heard. And then the prosthesis is placed in the storage solution. Now for the surgical technique of the K-Pro, the preparation of the recipient bed is similar to that of the standard penetrating keratoplasty. This is a patient that had 3 failed corneal transplants. She has eye syndrome, and she had 3 failed corneal transplants that was referred to me for a K-Pro. And as you can see, the cornea is opaque, vascularized. So after trephination, you can see that there is a broken IOL inside the eye. So initially I removed the broken haptic here. And then the remaining part of the IOL, the other haptic was stuck, and I had to excise it. And then the K-Pro is placed. So again, if the patient is phakic, a lensectomy is usually performed to avoid the need for cataract surgery in the future, and a phakic K-Pro is implanted. But if the patient is pseudophakic with a posterior chamber lens, then the lens implant may remain in place, except that, like in this situation here, you could see that the IOL is broken. It was right behind the cornea. It should be removed. And then at the end of the surgery, a contour contact lens is placed on the eye. As far as the post-op management, in the immediate post-op period, the preferred antibiotic regimen consists of topical vancomycin in combination with a 4th-generation fluoroquinolone, such as moxifloxacin, both dosed at 1 drop 4 times a day. Then to be tapered like 1 to 2 months after the surgery to 1 drop a day, or 1 to twice a day. And another recommendation is to put a drop of 5% betadine at each follow-up visit. Patients who have severe ocular surface disease are better to be kept on topical antifungals. Also, topical steroids, difluprednate 0.05% or prednisolone 1%, are used quite frequently after the surgery, like 5 times, 6 times a day in the first month, and in the first week, and then reduced to 4 times daily. And then finally, the patient can be maintained on a maintenance dose of once a day of predacetate 1%. And the contour soft contact lens that's placed at the end of the surgery is provided with the K-Pro, and it's left on over the eye at all times. And this lens, the purpose of it is to prevent drying of the ocular surface, DILIN formation, and corneal melts, and it should be exchanged for a new contact lens every 3 to 4 months. The complications of the Boston Type 1 K-Pro, the most common complication is the retroprostatic membrane formation, where there is a proliferation of fibrovascular tissue that grows to occlude the optic internal surface, causing decreased vision. Initially, it could be treated if it's a thin film, could be treated with a YAG laser, similar as for a PCO. But in advanced cases where the membrane is thick, it may require surgical excision and removal. The retroprostatic membrane develops more in eyes that had K-Pro for infectious keratitis, aniridia, or if they have anterior segment inflammation. And it was found that there is decreased incidence of the retroprostatic membrane formation in patients who had the titanium backplate model of the K-Pro rather than the PMMA. Another complication is infectious keratitis. As you can see here, around the optic, there is an infiltrate surrounding the optic of the K-Pro. The 2 large studies reported the rate of infectious keratitis to be 8 and 14%, with about 40 to 50% of these cases found to be fungal infections. The risk factors, again, the more complex the case, like patients with Stevens-Johnson syndrome, pemphigoid, chemical injury, have higher chances of developing infectious keratitis. And the management is similar to infectious keratitis otherwise, like cultures, of course, and the patient should be started on fortified antibiotics and antifungals without waiting for culture results. Glaucoma, of course, is the one of the most common complications of K-Pro, since it can either induce glaucoma or it can worsen pre-existing glaucoma. As you all know, these eyes are very complex and they already have mostly have glaucoma to start with. The glaucoma, like if it's de novo or if it's like new glaucoma, it could happen due to distortion of angled structures, retroprosthetic membrane formation, or peripheral anterior synechia. In those patients, one main issue with glaucoma follow-up is inability to measure intraocular pressure by conventional methods and the reliance on digital palpation. Also, visual fields are frequently unreliable since the field of vision could be limited by the small optic. And in these situations, optic disc photos and RNFL OCT could be helpful. Management initially would be with topical glaucoma drops. However, the majority of K-Pro patients require surgical treatment such as tube shunts or cyclophotocoagulation. The problem is tube shunts in these patients, or tube shunts could be associated with complications such as hypotony, erosion, and endophthalmitis. And given these issues, like with glaucoma and K-Pro, ideal candidates are those with no other options for vision rehab and older patients where the sequelae of glaucoma have less impact. Cornea melting or sterokeratolysis can also lead to consequences such as endophthalmitis, aqueous leakage, hypotony, choroidal or retinal detachment, choroidal hemorrhage, and extrusion of the device. As you can see here, one of our patients that was followed here before that had K-Pro, and you can see here in pictures A and C, there is melting of the cornea over the nasal aspect of the device with exposure of the titanium back plate. Also in picture D, you can see there are some bubbles between the bandage contact lens and the donor cornea, indicating that there's loss of corneal tissue there. Again, eyes with autoimmune diseases such as Stevens-Johnson syndrome and pemphigoid are particularly vulnerable to melts, leaks, and extrusion. Also, eyes with thick retroprosthetic membrane due to poor nutrition of the cornea. Initially, you could try with conservative measures. If there is no aqueous leakage, could have like a better fitting bandage contact lens. Lateral tarsorrhaphy could help. Could reduce topical steroid use if the patient is on a higher dose. Could use oral doxycycline to stop metalloproteinases. Surgical management. This patient actually was like, I remember him very well because he was like one of the very first patients that I operated on when I moved to Cleveland, just like a week or two. I had to do a cornea patch graft or lamellar corneal graft over the area of the melt. So this is one of the options. You could do glue, cyanoacrylate gluing for the melt or amniotic membrane graft. Or you could remove the K-Pro and replace it with a temporary PK, or you could exchange the K-Pro for another one. Endophthalmitis, the risk is higher, of course, in inflammatory conditions. Again, those patients with Stevens-Johnson syndrome, pemphigoid, and chemical burns, of course, have the worst success rate or worst retention rate of the K-Pro. They're more prone to more complications. Other risk factors include infectious keratitis, if the patient has a tube shunt and there is erosion of the tube shunt, and non-compliance with antibiotic prophylaxis. And those patients should be aggressively managed with K-Pro removal, vitrectomy, vitreous cultures, intravitreal injections of antibiotics. Unfortunately, these patients would suffer from poor prognosis, I mean. Other posterior segment complications include retinal detachment, choroidal detachment, vitritis, stoid macular edema, and retinal vein occlusion. So I'm going to talk now about two cases that I'm managing that, again, like, since the title of the presentation was to like the comparison between the artificial iris or the artificial cornea, maybe I would see if the audience can help me with decision making as far as those two patients. So the first patient presented to me a couple of years ago. He's a 36-year-old African-American male presenting with acute eye drops in the right eye. He's morbidly obese. He has sleep apnea. He had a penetrating graft done about 5-6 years ago that and he had, unfortunately, a ruptured globe in that eye that was repaired with a repeat graft and a vitrectomy. The right eye that I did about 2 years ago underwent an uneventful PK, but he was complicated by 3 rejection episodes in 1 year. The graft is still holding, but the best corrected vision in that eye is about 20/70 with glasses. He's intolerant to contact lenses. The left eye, which is a question eye here, the patient is aphakic, aniridic, and has a failed scarred PK graft. Vision is hand motion. Retina did a B scan, and he could benefit from surgery, but the decision here, and if he could, like with the pulling, if he could, I'm like the two choices that I'm thinking about are either to do another PK with a sclerofixated IOL and an artificial iris. Again, given the fact that like he had 3 rejection episodes, there's in 1 year, and the other option would be to do an aphakic K-Pro with a tube shunt. The second case is kind of similar.
Just give me 1 second. I'm gonna go ahead
yeah, of course,
and launch this poll
okay
about this first case, and we'll see if people are able to weigh in.
Mm-hmm.
And we'll just give it about 10 or 15 seconds here.
Or maybe we can add another option, like other option.
Yeah. Well, it looks like so we have seven answers now, and the 86% of the viewers are saying they would go with choice 1, the PKP, scleral fixated IOL, and artificial iris.
Okay. Very good.
Oh, we got another choice for that. Maybe. Did you have one way you were leaning, Dr. Omar? Do you want to talk about what your choice would be and why?
So initially, the patient, when I first saw him, I think like after I did his PK in the right eye, that was my choice to do the PK and the sclerofixated IOL and the artificial iris for the left eye. But the problem is, again, because he had the 3 rejection episodes in 1 year, and this would be the 3rd transplant for him in the left eye. I'm considering the fact that that graft would fail like very quickly. On the other hand, like going with the K-Pro and a tube shunt, he's still fairly young. He's 36, 37 now. And if he develops he probably would have glaucoma, and he most likely would lose vision from glaucoma pretty quickly. So again, it's a very difficult choice to make. But again, I see that the audience are going more with the PK, IOL, and the iris implant, and maybe in the comments or the questions section, maybe if they can have more comments or guide me more in the direction. The second case is also kind of similar. May I here? Yeah. Okay, the only difference maybe is the patient age. He's a bit older. He's 58-year-old Caucasian male with lattice corneal dystrophy. He had a PK also in the left eye that he also had a ruptured globe. The PK was done, I think, like 6-7 years ago. Also had a ruptured globe that also was repaired. And then he had another graft and a vitrectomy for a retinal detachment. And the right eye, which is the one that I operated on, I did a PK triple for him. Uneventful. He has best corrected vision with a contact lens. He has a clear graft there is 20/40, 20/50. He also in that right eye, that's why his vision is not better than 20/40 or 20/50. He has vein occlusion and cystoid macular edema that's treated with intravitreal injections. He is like a very aggressive steroid responder, even like early on in the course of his follow-up in the right eye, the one that I operated on. I had to switch him to loteprednol from prednisolone because his pressure, and he's on pressure drops, 2 or 3 drops in each eye. So now also the question eye is the left eye, also is aphakic, aniuridic, has a failed opacified PK graft, or I wouldn't say opacified. There's still some view, but there's a lot of scarring that it's not like it could not be fixed with a DMEC or a DSAG. So he would need most likely a PK. I mean, also the 2 choices again, same 2 choices like the first case, a PK, sclerofixated IOL, iris implant versus a K-Pro, an aphakic K-Pro, and a tube shunt.
All right, so I just launched that poll there, and we'll see what we get for this one.
Mm-hmm.
Okay. Give it another minute and see if some more people want to weigh in. K-Pro was in the lead, but now it's pulled to 50-50. So right now we have 6 responses, and it's half and half.
Half and half. Okay.
Do you want to talk briefly about which way you're leaning and why?
Yeah. So again, yeah, this patient. So I did his right eye, I think, back in August of 2019, and the plan was to do the left eye in around summer of 2020, which is just like a few months after COVID had hit, and the patient. The artificial, I was going with artificial iris, like with the PK, IOL, and artificial iris. And the artificial iris has been ordered for him, and it's been sitting in the surgery center for the last 2 years. The patient has been waiting for COVID to end to proceed with the surgery. He's like really afraid to proceed with any other surgery at the current time. That doesn't necessarily mean that I'm going with the artificial iris. I wouldn't say I have a huge experience with both, either the K-Pro or the iris implant. Just like few cases here and there. I feel like the K-Pro, especially in older patients, would do better. Even if the patient would have glaucoma and it could be managed with a tube shunt, we have our glaucoma team. They're very comfortable managing those cases, and I think I would lean more, especially if it's an older patient, with towards the direction of a K-Pro, given the fact that the surgery itself is, I would say, less traumatic. Say more efficient. It probably takes half the time of than doing the other surgeries. He could probably still need a tube shunt with the iris implant. I had a couple of the patients that I did an iris implant that one did not have a tube shunt. He needed to have a tube shunt very quickly in the follow-up period. Another patient, she had a tube shunt already in place, and I made absolutely sure during the surgery that the iris implant would not block. The iris implant was behind the tube shunt, but again, the patient, for some reason, developed like significantly high pressure in the post-op period, and also needed a tube shunt revision right after the surgery. So again, even like option one with the artificial iris implant supposedly should not cause any issues with pressure, but it could cause so, and the patient could eventually need still a tube shunt as well.
Yeah, it seems like the take-home message is there are a lot of considerations for these complex patients, and the answer isn't always very clear on what to do. And we don't have any questions. I think that was about the conclusion of the presentation. Is that correct?
I think so, yeah. This is the very last slide here. Yeah.
Cool. And so we don't have any questions in the chat right now. I do have one question I was a little curious about. In your video, you showing the K-Pro, you mentioned punching an 8.5 millimeter diameter corneal
graft
carrier.
Yes.
Graft for the K-Pro. Is that size standardized? And then kind of a two-part question. You also mentioned the high risk of glaucoma in those patients. Do you oversize the graft in K-Pro like you might in PK as well?
Correct. Yeah. So the size, the 8.5 is kind of standardized. This is the recommendation by Mass Eye and Ear, especially for the newer model. Like it's standard backplate 8.5. I've done a case a couple of weeks ago that because I did that, it was a failed PK graft, and the graft was already about 8.25. So I punched the donor cornea at 8.25, just like so that I wouldn't have because I stripped the previous failed graft, I didn't want to punch or like do another triffination, like would be uneven. So I did a 8.25 and it did okay. But that's the recommendation from Mass Eye and Ear. And the same thing was like regular like corneal transplants with a K-Pro, you oversize by 0.25 to 0.5 millimeter.
Great. And it looks like we still haven't received any questions from the audience. So thank you so much, Dr. Omar, for the presentation tonight and offering your expertise to us and the audience. Yeah, the webinar will be recorded and available on demand very soon. You will also, everyone who's here tonight will also be given a brief survey at the conclusion of the webinar. Please take the time to let us know how we did and any other webinar topics you might like to hear. So that's it. Thank you so much for speaking with us, and have a good evening, everyone.
As well. Thank you so much. Thank you, everyone.
Bye. Yep. Bye-bye now. Oh, wait. Sorry. We did get one question.
Okay. I thought I would play with it.
People are probably dropping off. It was a great talk, Ahmed. Can you comment on the national trial results from the custom flex artificial iris published in Ophthalmology in June?
Very good question. Is that question from who posted that question?
A colleague of yours.
Okay. Okay. I read the study. I can't really remember off the top of my head everything about the study, but it showed that the outcomes of the artificial iris were excellent in patients who have iris defects. Again, I can't really remember. It was just like published a month or 2 months ago, but unfortunately, I can't remember really the actual results, but they were very favorable for the artificial iris, of course.
Good. And a colleague of yours, of course, is Dr. Lass.
That's what I thought.
Well, thank you so much, everyone, and you guys have a good night.
You too as well. Thank you so much.
Bye-bye.